Welcome back to the For Your Best Self podcast. I'm Dr. Rebecca Novo. It's good to be back in the studio, and I have an exciting topic. I'm going to be talking to you about cosmetic breast surgery and what our consultation process looks like. I think I have a lot of information that's out there on our website in various places, but to kind of put it together in a thoughtful way, the most common topics that come up in consultation, I think it's really good information that you can have if you're thinking about breast surgery or someone that you know is thinking about breast surgery. So in general, there are two fundamental things that people most often want to change about their breasts. One is volume. We can either make breasts larger or smaller with various techniques, or the second thing is really to address sag, stretch, or what we call in the medical field ptosis, which is breast sag. And like I mentioned, we have various tools to address these two fundamental things. When we're talking about breast augmentation, we're typically talking about breast implants, and I'll go into detail about the choices there. Or another tool to augment the breast is fat grafting. So a lot of people like the idea of fat grafting, but you have to remember we have to take the fat from somewhere. So usually this is not an option in really thin patients. We really have to take the fat from your tummy is the best fat, or hips or flanks, and then bring that into the breasts. And we're a little bit limited in how much we can use so that that fat has the best survival. Another tool that we have is breast lifting, which is usually removing and rearranging skin. Another tool we have is reduction, and then sometimes these things are done in combination. So we might want more volume, but we might have to address sagging skin, etc. So those are the tools that we have just to keep it really simple. And then it's really important if you're thinking about breast surgery to understand kind of the three main anatomical landmarks. So everyone is unique as far as their breast landmarks. And I think although we like to see pictures and consultation and really listen and identify to the patient's goals of breast surgery, it is really important to acknowledge that there are limitations. For example, breasts at your clavicle or up at your collarbone is not normal, i.e. Victoria Beckham, a breast augmentation there is, going to be a push-up bra. Really high cleavage is ultimately going to be a bra, which is what I like to tell patients. So we all have a unique breast footprint, and that's really the top, where the top of the breast height is. And really, even with augmentation, we're only going to increase that a max a couple of centimeters. So we can't really artificially raise the top of the breast footprint with much longevity. And then it's important to understand that we all have a fixed width. The middle, or kind of the most medial aspect of your breast, is limited by your breastbone or your sternum. So as a surgeon, we don't want to change that, because that's when you'll get a uniboob, or synmastia that we call in the medical field. So we really want to respect these boundaries, because you're going to have the most longevity and natural result when we do. So we talked about the height, we talked about the width, and laterally there is a boundary, and most women are trying to not increase breast laterally or under their arm. That's usually inconvenient and uncomfortable. So we have techniques where we can narrow it some within reason. Another important part of the breast, and as a reminder, this topic is gender neutral. Men have breast surgery, women have breast surgery. A lot of the same principles pertain. Some men have breasts that are too large that they want reduced as well. So some of these techniques can be applied to them as well. So the second landmark that's really important in breast surgery to understand is the inframammary fold. Inframammary, that means under the breast. So everybody from birth has a defined inframammary fold in breast development, and that's where connective tissue really defines the bottom crease. If you're small-breasted, it's visible. If you're more heavy-breasted, it's hidden by the breast. So that's kind of the crease that has the most attachment to your chest wall. And then a really important feature to understand when we're changing the breast or assessing the breast is the nipple and the areolar complex. A lot of people say they want to change their nipples when they're really thinking areolar complex. The areola is the pigmented portion around the projecting nipple proper. And with age and weight and gravity, the areola typically stretches, or childbirth or weight changes, it usually stretches. And we usually have techniques to reduce this. But the goal in breast surgery overall is to get that nipple areolar complex centered in a more youthful position, kind of on the maximum projection or the furthest out part of the breast. And that's called the apex of the projection. So in medicine, we have a grading system for sag. Most patients call it sag or stretch. And now that you know where that inframammary fold is on your body or your loved one's body, our sagging or ptosis scale is all relative to that. So in a perfect perky, healthy breast of a 18 to 30-year-old, that nipple areolar complex is above the inframammary fold. For grade 1 sag or ptosis, we would say it's about at that fold. Moderate ptosis or sag is when the nipple is below the inframammary fold. And then we consider severe ptosis or sag when the nipples are pretty much facing the ground, which is a lot of women's case with aging and loss of elasticity and connective tissue fibers of not only just the skin, but the deeper breast tissue structures. And the biggest culprits are aging, having children and nursing, and weight changes. There's also a category called pseudotosis, which is when the nipples are in a pretty normal position or above that fold, but then you have a lot of breast tissue or gland under the fold. So with these categories in mind, you can kind of see how a surgeon would look at the breast and say, identify the patient's concerns. Are we going to address volume? Are we going to address sag? Are we going to want to reduce weight that's straining your shoulders or back? Or are we going to want to do a combination of these procedures? So let's talk about incisions. There's a variety of incisions we may use alone or in combination. When I'm doing a breast augmentation, my favorite incision is the inframammary. It's in that fold that we talked about. It's a few centimeters wide, and it blends really nicely over time. I find in my experience it's the safest, gives me the best visibility, and least complications of infection, bleeding, abnormal scar tissue. Breast augmentation can be done through the areola, the armpit, or rarely the belly button. But I find inframammary is the safest. And I always like to educate patients implants are not lifetime devices. So even though you could go in the nipple the first time or through the armpit, you may or not be doing your revision surgeries in the scope of your lifetime through those same incisions regardless. So there's also a periareolar incision, and this is when the scar is kind of blended. Either we want to reduce the size of the areola, or you could do a small lift around the areola. If you don't have to remove a lot of skin, say in the few centimeter ranges, you can easily hide a scar in this border where the pigment meets regular skin. So you can do a periareolar incision when you have mild ptosis. Most commonly, I'm using a lollipop incision. If you visualize a lollipop, a circle, and then a stick, the circle is the circumareolar incision, and then that vertical stick allows me to remove extra skin and kind of use some of the deeper breast tissue to help support any lift. And that's usually what we're using when there's moderate ptosis. When there's severe ptosis or sag, or maybe we want to reduce the weight of the breast in a traditional breast reduction, we're going to use a WISE pattern or the famous anchor incisions. So it's like if you envision the lollipop incision around the areola, vertical down the middle, and then the anchor, or the bottom, is anywhere from the middle to the entire inframammary fold. And that really depends on how much skin or tissue we need to remove. And these usually all fade really well with good technique and good post-care. When people ask about scars, I tell them I have scars that look like fine pencil lines, and I have scars that look like fingers. It really depends on tissue quality, tissue integrity, as well as technique and post-care. So we definitely want some anti-gravity support while we're healing, and I'll go into that in the post-care portion. So if we talk about implants, my favorite myth is every patient wishes they would have went bigger. This has not been my experience. I can count, luckily, on one hand how many patients have wanted to increase the size of their implants, and just know that there is a limit. Most of my patients say, I woke up much bigger than I ever wanted to be, not in my post-ops, but patients that come with implants in consultation say they regret how large of the implants they were given. And that being said, a larger implant should not be used to compromise if you really need a lift. So all of this is reviewed on physical exam, and the surgeon's job to really educate you what the best choice is. So this is my myth buster. Not every patient wishes they went bigger. There is a limit, and I'm pretty conservative as well, and most patients that come to me want to obviously look augmented. They want to look different, but they don't want that to be the first thing that everybody stares at. So they usually want to feel more feminine, fill out clothes, maybe have their body feel more proportionate. But there is a limit. Over 300 cc's, implants have weight, and they are going to stretch the overlying tissue. So a more conservative implant is going to have more longevity on any surgical result long term. The larger you go, there's more of a weight. It is inevitably going to stretch your tissue over time, especially when you're talking about combining procedures like an implant lift or implant augmentation, mastopexy. So I think that's really important to remember. And I always tell my patients, we do it. Surgeons around the world do it all the time. But there is some increased risk in combining counterintuitive procedures, such as an anti-gravity procedure, such as a lift or mastopexy, with a weight, such as an implant, even though we want that tool for volume. So I'll go a little bit over implant selection. I think it is really critical to listen to your patients, or listen to my patients. I want to hear their goals. I want to hear their concerns. There's also a great app that I encourage them to use in the comfort of their home. It's free. It's called My Natrelle, Natrelle. I used mostly Natrelle implants. So this is a really nice app where you can do 3 photos front, side, and you can kind of ghost or shadow some virtual augmentations and play with different sizes and get an idea of what that is going to look like on your body. So I encourage that. Definitely look at before and afters, but keep in mind, do not fall in love with a number. I've had patients with no breast tissue say they love pictures of girls with 400, 500 cc implants. If you really don't have a lot of skin or ability to stretch, it's really not going to be feasible, definitely at the first surgery, to get that size of an implant in. And then we also have to keep in mind those boundaries, the lateral portion of the breast, the medial portion of the breast. What is actually going to fit? How much skin do you have between the nipple and the inframammary fold before you run into complications? So There is a limit to size, and I think that is best decided in consultation. They're mainly, saline and silicone implants are our two main choices. And there's pros and cons in both. Saline is much less expensive, and I say the biggest selling point of saline is that there's no surveillance or imaging that we really recommend or that's required. If a saline implant ruptures, it's going to deflate. Your body's going to reabsorb the very safe normal saline, sodium chloride. We put in sterile sodium chloride into the implants. Your body's going to resorb that. You're going to know it. Your breast's going to deflate. There's no urgency or emergency to have them exchanged or changed or removed. Most people want to, but it's not an emergency by any means. So I would say that is the biggest selling point of saline. A con about saline is that they usually feel a little bit tighter, less soft, squishy, natural. So most patients choose silicone. I think another benefit of saline is that we talked about cost. You can sometimes do smaller incisions because even with the color funnel, which I'll use in every silicone implant, and I'll talk about that, you still have to squeeze a larger volume through an incision, versus the saline, is maybe 2 centimeters wide. That's really the only width that you need to fit that in. So smaller incisions, safer in a sense that you don't need any extra imaging other than routine mammograms. And if it deflates, you know it and it's safe. I do like to point out the difference that even though it's saline, you're not avoiding silicone in your body because there's a silicone shell. So I think that is important to understand. And then also saline's approved at 18. Silicone medical legally is approved for 22 and up. Silicone pros and cons, some I touched on. They're softer, squishier, if you will. I think modern implants have come so far as the cohesivity, the technology. I tell patients that if you were to cut a Natrel implant into the highly cohesive or gummy bear implant, it really is going to stay in two pieces. It's squishy and soft, but it's not a liquid. You may have seen some of our videos on Instagram or explant videos where there's like a slime and a goo. That's me taking out implants that were black boxed from the 90s. Those are your Dow Corning liquid silicone implants. So implant technology has improved. The safety profile has improved. And I think that silicone is usually the most common aesthetic choice. That being said, they're completely customizable. You can change the millimeter of width, projection, height, volume. So it is really important to identify goals with your surgeon. And just to touch on the topic of lifespan, it is really important for me to tell my patients that they are not signing up for one surgery. They're signing up for some future surgery as well, whether that's implant removal, implant replacement, or lift over time. On average, another myth buster is that I've heard of surgeons sending out postcards. It's been 10 years. It's time to change your implants. It's absolutely not true. Studies have shown we know on average the lifespan is 10 years, and that's where that 10-year buzzword comes from. I've heard of patients, their saline implants rupturing after surgery within weeks. You hear about patients with 30, 40 or plus implants. So there's really no way to predict or timestamp. They don't expire. It's just really important to understand what to look for, what's safe, what's not safe. It is my job to tell all patients that are going to have silicone implantation that the guidelines recommend imaging every 3 years. That could be ultrasound or MRI to look at the implant shell and look at its integrity. That is completely separate from a mammogram. Mammograms are designed to look at the breast tissue. And even if a patient's mammogram suggests implant rupture, I'll have them get an ultrasound or an MRI. They're just more sensitive for the breast implant integrity. So that being said, a silicone rupture, the urgency to have those exchanged or removed, to me, really depends on the age of the implants. When were they placed? What type of implants were they? Who made them? It's tricky because a lot of women don't save their implant information, and that makes my job a lot harder, just in a sense of information if you want an exchange, and we're talking about volumes. So if you have your information, bring it to your surgeon in consultation. Or if you don't have your information, try to find out, try to track down your surgeon. These are all tracked now. Every time I do a case, I'm giving the serial number on every single implant that gets registered. And that's really to ensure safety and device tracking on patients. So that pretty much covers saline and silicone. I think that it is important to note that textured implants have been removed from the market. There is a very, very, very rare but real risk of a rare blood cell cancer linked to some textured implants, not all. And it's thought to be due to kind of an inflammatory reaction to the texturing process in some implants. So that being said, if you have textured implants, it's not an emergency to have them removed or exchanged. Guidelines currently say that if you're having symptoms, pain, swelling, or any change, definitely have them evaluated. The first step would be an ultrasound looking for a peri-implant fluid collection, and that fluid would be sampled for any atypical cells. So it is important to know. I've taken out quite a few implants that the patients didn't know they were textured recently. So it's always good to kind of, as a surgeon, we like to know what we're going to get into, so just that information is helpful. And also a nice side note is that implant companies are reimbursing patients for implants that are textured for their exchange. So that's good news too. I have a question from the audience. How much sensitivity loss can a patient expect? This is a good question. So technically with augmentation, not violating any nerves that supply sensation, it can be diminished. Anytime that I do a surgery in the post-op, I see them at 1 day and very closely for the first few weeks. I assess nipple sensation. You want to know baseline, so we'll do an exam at the consultation for baseline sensitivity. I always counsel that may be diminished. As long as it's not absent, it's going to come back. And sometimes the contrary, the sensation is hypersensitive. So that's usually more bothersome to patients, and they'll get silicone covers, and there's ways to kind of calm that down. But it's a range, very, very rarely, a rare but real chance of complete loss of nipple sensation. That would be very unusual. Usually it's diminished and it comes back over time. Another question, do implants float? They don't float in a sense because saline is the weight of water. You know, the saline that's put in the implant is the same weight of water. So unless there was an extraordinary amount of air, which would be a mistake in that implant, they really shouldn't float. And silicone's actually more dense than water. So it's not going to make you sink in a pool, but I think the biggest thing is people notice they get cold. If the water temperature is colder, they might stay cold a little bit longer, which is interesting. Will they affect scuba dives? I don't know. I'll have to find out. I'm sure there's plenty of scuba divers with augmentation and implantations. I'll get back to you on that one. Okay, so that's typically what I cover in my consultation as far as the intro. We're going to come up with a plan. We're going to examine you physically. You know, I'm going to look for any lumps, bumps, any abnormalities. I'm going to look at you while you look in a mirror. I'm looking at you so that we're looking and talking about the same exact thing. So I can hear your concerns and I can point things out and teach you at the same time. So we're going to come up with a plan. And then we're going to propose that. My patient care coordinator will review finances with you and show you dates if you're interested in scheduling at that time. Prices do include everything other than labs, pain medications, and the very, very rare but possibility that you would need a reoperation. Why that would be: bleeding, infection, choosing to change the implant, make it bigger, make it smaller, or anything. Usually if surgery is needed within a year of my surgery, I don't charge you my time, but we do have to cover anesthesia and facility fees, and that's all included in our surgical quote. So we have a plan. We've talked about what we're going to do to make your breasts look the way you'd like them to. And then, so you're scheduled, and then you're going to come for a preoperative visit. We're going to talk a little bit more in detail about how to prepare and what your recovery will be like. We're going to size you. That's the point where we're going to do photographs, and we're going to try on some implant sizers if implants are part of your plan. We're going to take measurements. Those are important to kind of track your results over time. And then we're going to talk about how to prepare for surgery. I think weight is an important topic. I have some patients that come and want surgery, but then they'll say, but I want to lose 40 pounds or whatnot. I never tell patients they need to lose weight. It's not my job. Unless their BMI is over a certain threshold, which is typically 30. And then it's my job to educate that with a BMI over 30, there's apps all over. You can get a BMI app. It's a formula of height and weight combination. If your BMI is over 30, which is overweight, we know you're slightly higher risk of infection or wound healing complications. So that's my job to educate. I will do surgery with a BMI over 30 if you're otherwise healthy, as long as your personal goal is not to change weight drastically, because that's really going to affect your results long term. I say if you can be within 5, reasonably 10 pounds of your goal for 3 to 6 months before surgery, then it's okay. But if you want surgery yesterday and your goal is to lose 40 pounds, it's not the right time. So I think weight is an important consideration, and not everybody can change their weight or does change their weight. When their weight shifts, not everybody's breasts change. But if it does, then that's really going to change maybe the plan and the result, the longevity of that result over time. So that's an important consideration if you're thinking about breast surgery. And also diet. I don't believe in trend diets or binge diets or restrictive diets. I think, we need protein, we need fiber, we need nutrients. You need certain stores of vitamins and protein to heal. So it's definitely not a time to go on a restrictive diet, starvation diet. It's just going to cause problems. I will check certain labs in massive weight loss patients to make sure their vitamin stores and protein stores are stable. So diet is important. Surgery is not a kickstart. It really should be a refining procedure once you've kind of done the work and you're happy where you're at for a stable period of time, and that's usually 3 to 6 months. I encourage all my patients to make healthy lifestyle choices. It sounds like common sense, but sleep, the importance of sleep to healing, minimizing stress to healing, getting, every few days a dose of exercise so that your cardiovascular store reserve is good. Not smoking, I don't operate in smokers. At least 6 weeks before and after, strict smoking cessation, even if you're vaping and there's nicotine and different chemicals in that, it can really affect your wound healing. We're really relying on the microvasculature, the teeny tiny blood vessels, to heal, get oxygen to the healing areas, and so that we can minimize infection and things like that. As far as recovery, I tell patients on average it's going to be 6 weeks before you can fully return to your activities. Granted, you're not going to go back at 100%. You're going to ease back in at 25%, maybe the first week, 50%. So a graduated return to your previous exercise programs. Why that's important in breast surgery is because, A, we don't want anything that's going to stress or strain our anti-gravity healing support. We don't want a lot of sweat or irritation or inflammation that could increase chance of infection or delayed wound healing. And we really want to specifically minimize how much the pectoralis major is doing. That is really your pushing and pulling muscle. To circle back a little bit on implants, there's really two main places to put them: under the breast tissue or under the muscle. And that's really customized per patient physical exam and lifestyle. It used to be kind of a knee-jerk reaction. If patients were super skinny, you'd put them under the muscle because you wanted that camouflage, or you wanted to hide that the top of the implant so it didn't look like a shelf. But most of my teeny tiny skinny, no body fat, no breast patients are the ones that also like to do CrossFit, and they're in competitions. So if we're going under the muscle and you're pushing and pulling, you're really going to displace that implant. I think another really good myth is that going under the muscle holds implants up. And if you think about it, if you Google pectoralis major, this is the muscle that we are lifting up to conceal implants sometimes. It runs from your shoulder to your chest bone. So we really lift that up almost like the top of a curtain, and it comes off the ribs and the chest wall to really add as a camouflage to the top of the breast. Modern breast implantation is not done completely under the muscle. It's usually a dual plane where you're using the muscle on the top, and then the breast tissue is over kind of the second half of the breast. So, long story short, if you're very physical and active, I usually counsel those patients that we don't necessarily want to go under the muscle because they're going to run into a lot of animation deformity, meaning every time they push, pull, lift, strain, their implants are going to move and shift in an abnormal way because it's all going to be connected. The scar tissue around the implant is going to move with the muscle movement. So that's another conversation to have in consultation, and that's completely customized. The plane or the placement of the implant is really important to identify and hear your lifestyle. What do you do? Like I mentioned, modern implants are completely customizable, so we don't necessarily need to rely on the muscle to hide it if we're picking a conservative, kind of more sloping implant. So those are some nuances of implant selection that we can go over in your consultation. As a former athlete, I feel very comfortable kind of guiding and educating my patients in their post-care. I'm not a personal trainer by any stretch, but I do offer a lot of advice on what's safe. Most patients are really anxious to get back into something So I feel very comfortable coaching you on what you can and can't do so that you feel good and you're moving your body and you don't feel like we're punishing you with a 6-week. It's not a 6-week bed rest sentence. So 6 weeks is kind of the ballpark. If everything's going well, healing well, no issues, we'll ease you back into your exercise plan at 6 weeks. Most patients are feeling good within a few days to weeks. You actually have to remind yourself to slow down, take it easy. You're going to wear a support garment. We provide a really nice post-op bra, and it's not designed to squish or squash the breast. It's really designed to help facilitate anti-gravity healing support at the bottom, the sides. It's going to help reduce swelling and just really support the breasts as they heal. The most important thing is anti-gravity. You're pretty much going to live in it night and day, other than hygiene or showers, what I tell patients. Most patients want to buy a backup bra that they can change, launder, and whatever you're comfortable with. So as far as the consultation experience, our plastic surgery consultations are complimentary currently. You're going to be asked to change into a gown so that we can do a thorough exam. I'm going to ask you about your history, both your personal and family history of any breast disease, biopsies, lumps, bumps, if you've had any imaging like mammograms or procedures. Please, I can't stress enough, if you have your implant information, to bring it, or if you know how to get it, to track it down before consultation. We're going to talk about your medical history, your smoking history, and again, we're going to look together in a mirror to review your goals and then come up with a plan. So I have really covered, I feel pretty thoroughly, my breast consultation. Again, it's completely customizable. I think that is really important to identify and manage expectations, what is and what is not possible. Sometimes we'll combine procedures like liposuction if we need to thin out the lateral aspect of the breast, or add fat grafting if we want a little bit of volume, if there is a fat store, to do some auto augmentation. But really, these are the main points that I wanted all patients to be able to have, some myth busters and just some general information so that you can go to any breast consultation a little bit more informed. So thank you for listening. If you have any questions from this episode, please email us at foryourbestself@gmail.com. I'm also Rebecca Novo MD @gmail.com if you want to reach out to me personally. If you enjoyed listening to this, please subscribe to our podcast. We are on Spotify, we are on iHeartRadio, we are on Apple Podcasts, really anywhere that you can find podcasts. Tune in. Also visit our website. I have a lot of information before and afters on these types of surgeries at www.foryourbestself.com. You can also follow us on Instagram and Facebook. Instagram is Dr. Saluja _Dr. Novo, and Facebook is at Dr. Saluja. Help us grow our audience. Share this podcast with anyone you know or love that is thinking about breast surgery.